We're here with Salmon Substance Abuse Prevention Coalition, and we're very excited to introduce Dr. Ken Finn this evening. Ken Finn has been practicing pain medicine in Colorado Springs since 1994. He is board certified in physical medicine and rehabilitation, pain medicine, and pain management. He is president of the American Board of Pain Medicine and has served on their exam council for 20 years. He served on the Colorado Governor's Task Force on Amendment 64, which legalized marijuana for recreational use, consumer safety, and social issues work group, and serves 4 years in Colorado's Medical Marijuana Scientific Advisory Council. He has testified to the Canadian Senate on their marijuana bill and speaks internationally on the health impacts of marijuana, including being an invited speaker to the Mayo Clinic, Jacksonville, the Royal College of Surgeons in Ireland, UCLA, VA Medical Center, and the Texas Medical Society. He is the editor of Cannabis in Medicine, an evidence-based approach, and currently the co-vice president of the International Academy on the Science of the Impacts of Cannabis. And with that, we will turn the time over to Dr. Finn.
Thanks, Sharon. I do appreciate the opportunity. There's a lot of ground to cover, and I'll try to be as concise as possible. And I think at the end, we'll open it up to questions. And if folks, as I go down this presentation, because I'm covering a lot of ground in a lot of different areas, put your questions in the chat box. And I think Sharon can go over those at the end, and we can take it from there in a sec. Hold on. All right. The first thing I want to talk about is the relationship between cannabinoids and opioids. And as Sharon mentioned, I've been a pain medicine doctor here in Colorado Springs for a long period of time. And the reason I ended up going down this road was the fact that patients were coming to me on high doses of opioids, which is a problem. They were reporting very high levels of pain, and they were using marijuana for their pain. So nothing really was helping them with their pain condition. So I started reading more about cannabis and the cannabinoids and the endocannabinoid system, and have decided and come to the conclusion, and there's a lot of data on this, about how intricately related the opioids and cannabinoids actually are. Just a disclosure, I do get occasional honorarium for speaking. It's not, trust me, a retirement plan that anybody should go down. I do get very small amount of royalties for my book. Again, not a good retirement plan. So on the screen are some molecules of cannabinoids. One is the real delta-9 tetrahydrocannabinol that everybody's familiar with, THC. The other one is cannabidiol, or CBD, which is the non-psychoactive component of cannabis. And the other one is a synthetic THC, dronabinol, that has been around for nearly 40 years that patients never asked me about. I mean, we have already synthetic marijuana that's been around in a medication form for many, many years. So that's what they are. And you can see in the 7 o'clock position, there are some differences in terms of the molecular structure, and that might be the reason of where they act somewhat a little differently. So if anybody spent time taking care of patients in pain, it could be very frustrating, challenging part of medicine, but at the same time can be somewhat rewarding. This is a very important slide to understand what is the difference between cannabis-based medication and medical cannabis, which medical cannabis, that's where dispensary cannabis falls under that umbrella. Cannabis-based medications are extracts that have defined, standardized content of THC or CBD or ratios of both. And examples are the dronabinol I mentioned, or nabilone, that's been around for several decades. You have Sativex, which is not available in the US. It's a natural 1-to-1 CBD THC ratio. And then Epidiolex, which is a FDA-approved pure plant-based CBD. It's been approved for a very narrow spectrum of pediatric seizures. Medical cannabis, on the flip side, are just parts of the plant, the flowers, the buds, leaves, extracts that are used for medical reasons, but they're fraught with a lot of problems in terms of regulation and testing for contaminants. So if you ask why people go to their doctor, the National Ambulatory Care Survey I've been following them for about 15 years. The data really hasn't changed much, but why do people go to their doctor? They go for hypertension and obesity and asthma and diabetes. But in the top 20 diagnoses of the entire country, why they see their doctor, there's only one pain diagnosis, and that's knee pain, most likely related to osteoarthritis of the knee. The things that are not in the top 20 are back pain, cancer, seizure, fibromyalgia, neuropathy, etc. So I want to talk a little bit about, and I don't want to get too sciencey, but I want to try to explain this and this relationship between cannabis and opioids. That they kind of work hand in hand. They belong to the same kind of receptor. They're called G protein coupled receptors. When they're both activated, they do the same type of thing by decreasing the intracellular levels of a chemical called cyclic AMP. And by doing so, it modulates different neurotransmitters, some of which modulate pain. They're found at the presynaptic endings of the nerves. They co-localize in what are called GABAergic neurons, which are the neurons in the central nervous system that modulate pain pathways, and they share pharmacologic profiles like sedation, drug reward, and even anti-nociception or pain relief. And actually, naloxone, which is the antidote for opioid overdose, has been shown to have effects on the cannabinoid system in animal models. So there's this very intricate, tight, overlapping relationship between the two. So if you look at the data in the medical literature, the most common reason people are typically using cannabis is for pain. In my world of pain, that's a huge umbrella. You've got, like I described, knee pain, back pain. There's neuropathic or nerve-related pain syndromes. There's visceral pain. There's psychosomatic pain. So there's a very big umbrella. But if you look at some of the other diagnoses, like spasticity is very low, sleep problems, nausea and vomiting, et cetera. Pain by far is the most common reason people use cannabis reportedly. So we do know that we're in the middle of an opioid epidemic. And going back in time, and I don't want to go through the volume, because there's a lot of volume and data in the medical literature on whether or not cannabis is effective for pain. And going back about 5 years, a paper that is very often quoted is the National Academies of Science paper that was published in 2017. And the conclusion of that was there's substantial evidence that cannabis is an effective treatment for chronic pain in adults. So I have the link here, and I'm more than happy to share these slides, and all of my slides are cited. But if you look at the details of that particular paper in the pain section, they looked at synthetic cannabinoids, which I already explained, like the dronabinol or nabilone. They are FDA approved, they're very controlled. And the nabiximols, the Sativex of the world, which are naturally occurring, purified, pharmaceutical grade cannabinoids that is not available in the US. They did not look at dispensary cannabis or medical cannabis. So I think that this particular paper was somewhat flawed in that respect. Oh, and the other thing is that they looked at less common diagnoses. They looked at cancer pain and nerve-related pain or neuropathic pain, not common pain conditions. So as we go down the road in the literature, Bachhuber published a paper back in 2014 showing medical cannabis laws show lower state-level opioid overdose mortality rates. So this is kind of the bandwagon was starting that, hey, maybe this is going to be a good analgesic, maybe it's going to save our opioid problem and help our opioid epidemic in crisis, showing that medical cannabis laws show lower deaths. Bradford, a few years later, showed medical cannabis laws are associated with reduction in opioid prescribing. But in this particular paper, it was a very select population, just the Medicare D population. They did not look at whole population data. So around the same time, the data started to emerge that there is no evidence that cannabis reduced pain severity or showed an opioid sparing effect. That was in 2018. And actually, Chelsea Shover and Keith Humphreys from Stanford in 2019 used the same methodology as Bachhuber and actually demonstrated that states having medical cannabis laws had actually nearly 23% increase in overdose deaths, not a reduction. Babylonis from Kentucky around 2019 scoured the medical literature again, and the data just doesn't support the use of cannabinoids for chronic pain, and studies don't show a good opioid sparing effect. Segura at Columbia University in New York published a nice paper showing that medical marijuana law enactment does not show a reduction in prescription opioid use, contradicting the hypothesis that people would substitute marijuana for prescription opioids. Kim, earlier this year, there's no overall protective relationship between medical cannabis laws and opioid overdoses. And this kind of counters again the claims that there's a protective effect of medical cannabis on opioid overdoses. This was a very interesting paper that came out a few months ago. And just as an example, given my experience dealing with patients that have medical marijuana cards and living in Colorado, I was curious to see what it would take to get my own medical marijuana card. So I actually applied in 2021, and I was approved in a minute. I got my medical card in 60 seconds via virtual telehealth visit with a physician, and I didn't make anything up. I need both my knees replaced for being a very active youth, multiple knee surgeries, and the physician never asked to review my MRI, didn't even ask to look at the scars on my knees to make sure I wasn't lying, didn't ask for any medical records, never even asked my level of pain, which on a day-to-day basis is about 0 to 2 on a 10 scale. But I was approved in 1 minute for severe pain. So off I was able to go to any medical marijuana dispensary in the state and get whatever I want. And it kind of underscores the concern, at least here in Colorado, the law is you can get a medical marijuana card at age 18 without parental consent. And you have that window between medical marijuana and legal marijuana of 21 years of age. So these young people in that window can easily get their medical marijuana card without having to go to the legal marijuana dispensaries because the products are all the same. But this paper came out a few months ago showing that if you acquire a medical marijuana card, that has a higher incidence and severity of cannabis use disorder and no improvement in pain. So kind of the ongoing emerging data, the mountain of data is showing it's not a good analgesic, it's not replacing opioids, and we're still in the middle of an opioid crisis. But the platform to legalize is exactly what's not happening, that it is going to be an analgesic and it's going to cure our drug crisis. This was a very interesting study that came out that oral synthetic cannabis products that have a high THC to CBD ratio may be associated with some improvements of chronic pain and increased risk for dizziness and sedation. And these are the products that are already available. I'm talking about the dronabinol and the nabilone that are FDA approved cannabis-based medications, not medical cannabis. Want to talk a little bit about the receptors again, and try to underscore this ongoing tight relationship between cannabis and opioids. So if you look at the Youth Risk Behavior Survey from a couple of years ago, it comes out every couple of years, the number one risk factor for adolescent opioid misuse. So kids that are misusing opioids, the number one risk factor is having ever used marijuana in your lifetime. Another article came out in JAMA a couple years ago that after 3 years of first trying marijuana compared to opioids, marijuana actually has a higher percentage of addiction in adolescents compared to opioids. And I'm going to go over some of this data and the graphic from it because it does really highlight and underscore this relationship, especially in the developing brain. Wadaker's study came out a couple of years ago. I found very interesting. He was actually a high school student. They used a very intricate matrix on what predicts adult opioid misuse. And at the end of the day, the predominant predictor of an adult misusing their opioids is a history of using marijuana before the age of 18. So here's just 3 little data points highlighting even adolescents and adults. If you start with marijuana, you may have problems with opioid misuse down the road. Olson study that came out, I think in 2019-ish, cannabis use increases the risk of developing opioid use disorder. And this is a very large study. They started with 45,000 people in the early 2000s and followed up with them 3 years later. And 3 years later, they had, I think, a total number about 34,000 respondents. And of those that had reported cannabis use, those patients tend to have a higher problem with opioid misuse or developing opioid use disorder. And if you look at the fatality analysis risk survey and the National Roadside Survey, in drivers that are testing positive for marijuana are more likely to have or test positive for prescription opioids. So again, this link between these two types of substances, and these data are more than other substances, more than alcohol, more than cocaine, more than methamphetamine. So the number one thing they're finding in these studies is that drivers who have marijuana are more likely to have prescription opioids than other substances, which is an important point to make. Another very large data point, nearly 76,000 adults over the age of 50. If you had used marijuana within the past year, that was a significant association between the odds of having opioid dependence or past year non-medical use of opioids. This was very interesting because as a registered medical marijuana patient in Colorado, looking at what do medical marijuana patients, how do they use their marijuana? This study shows that medical marijuana patients use marijuana more, they have more problematic marijuana use, and they only use medically about 23% of the time. I mean, 20% of the time. Medical marijuana patients tend to use recreationally about 80% of the time. So are they really medicinalizing their recreational use, or are they actually using for a medical condition? So if you look at last summer, a very large international organization called the International Association for the Study of Pain, or the IASP, scoured the literature and concluded that there's a lack of high quality clinical evidence, and they do not endorse the use of cannabis or cannabinoids for pain relief. And that was followed like within weeks of the Australian New Zealand College of Anesthetists, the pain medicine faculty. The evidence that's available does not support using cannabinoid products for chronic non-cancer pain, or is just terrible quality that you can't even make any conclusions out of it. So you have the Australian Pain Society, the New Zealand Pain Society, the British Pain Society. All of these national, international organizations are basically saying it's not helping with pain. They don't support its use. The studies are poor quality. There's no positive evidence. I did like the European Pain Federation paper from 4 years ago, because they did try to clarify the difference between medical cannabis and cannabis-based medications, because there is a difference. There's just really not a lot of evidence out there. We already have a black box warning on the use of opioids with benzodiazepines like Valium or Xanax because of the risk of overdose. So the European Pain Federation does not recommend using cannabis-based medicines that are on opioids or benzodiazepines. And they were the first organization to address potency. They do not recommend anything more than 12.5% THC, which I'm going to get into some of the potency issues and concerns that we're dealing with in our state right now and in other venues. The National Institute on Healthcare in the UK, they don't even recommend using the synthetic cannabinoids like nabilone or dronabinol, or a combination of CBD with THC. And they don't even they went to the point saying don't even use CBD to manage chronic pain unless it's part of a clinical trial. So this tells me the data is just not there. Our medical society has some recommendations on a 15% potency limit. I think it should be 10 or less. Texas Medical Association has, they do have CBD. They recommend following science-based guidelines, but there are no guidelines at this point. So, we know we're in the middle of a drug crisis, and you can see over time, fentanyl's kind of spun off into its own beast, and we can talk a little bit about that later. But if you look over time, our national drug overdose deaths per year continues to go up at the same time more states are legalizing for it. And we know that based on the data I showed earlier, that the most common reason people are using cannabis is for pain or pain relief. but it's not helping our national opioid overdose death data. This is going through November 21. It even has gotten worse. 106,000 people died from drug overdoses. Again, you have to understand that this is at the same time more states are legalizing for both medical and recreational. This is a very nice graphic over time. The Colorado Health Institute opioid overdose death by county. If you can see my cursor, I can't see it here, but I live in El Paso County, which is almost in the middle of the screen, kind of central, east central in Colorado, about an hour south of Denver. And these are our Colorado drug overdose death rates going back to 2002. And so just a very short history of Colorado's marijuana road. We voted for medical in 2000 with Amendment 20. We implemented in 2001. And I'm going to talk about what happened after that in a minute. But if you look at our overdose death rate going back to 2002, with the understanding that 90% of Colorado's medical marijuana cards are for pain, and the platform to legalize is going to help our drug problem. This is what happened in Colorado. 2000, and the darker the color, the worse drug overdoses you have. So 2002, 5, 8, 11, and 14. It's simply not helping our drug problem. And I think there was a paper I mentioned earlier, our prescriptions of opioids are on the decline, yes, but despite that, our overdose deaths continue to rise. And here's a better graphic of the Colorado data, looking at 2000 when we implemented or voted for medical, implemented in 2001. In 2009, we had, for lack of a better term, de facto legalization when all the dispensaries popped up across the state. And then in 2012, we voted to legalize it for recreational purposes and implemented that in 2014. And interestingly, heroin has been on the decline as readily available and cheap it is. I believe that fentanyl is the new heroin because the heroin overdose deaths continue to drop when the other deaths continue to rise, because all of these drugs play well in the sandbox, including cannabis. And I do a lot of work with the Colorado Department of Public Health and Environment, CDPHE, and over time, there seems to be more mentions of cannabis in our state's overdose data set. And I'm working with our state to try to help clarify that, because you need to differentiate between, are these the synthetic cannabinoids that are associated with these deaths? Are they companion drugs in somebody may have overdosed on fentanyl and they found that it was a contaminated marijuana product or laced with fentanyl? And you can look back in 2019, we only had 220 fentanyl related deaths. This is the 2021 deaths where fentanyl went up almost 100% in 1 year. And you can see the other opioids continue to go up. Heroin kind of stayed flat, but cocaine and meth are making a strong comeback, again, because all these drugs do play well in the sandbox. And here's the 21 data. It's just getting worse. Heroin is still on the somewhat a decline, but fentanyl is going through the roof. Methamphetamine is going through the roof. Cocaine is going through the roof. Prescription opioids are going through the roof. It's not helping our drug problem here in Colorado, despite what the media is telling everybody it is. It's an opioid substitute. It's going to solve our drug problem. But if anybody can look at this graph and tell me where it's helping, I'd love to have the discussion with you. California's doing the same thing. They've had medical marijuana since '96. Buprenorphine is going up. Prescriptions are going down. Co-prescribing opioids and benzos are going down, but their drugs are going up. Drug overdoses are going up. Again, I'm going to highlight that the more states are legalizing for marijuana as of May of last year, 36 states. I think there's 38 now. I just published a paper with a gentleman in Oregon, Archie Blyer, who's at the University of Oregon. His colleague, Brian Barnes, and myself published a paper a few months ago. Opioid deaths have increased more where marijuana was legalized. So it kind of flies in the face of this ongoing platform and false narrative that marijuana is an excellent opioid substitute and an effective analgesic. It simply is not the case. And in this particular paper, we looked at, especially for fentanyl, has gone up a lot. And in this day and age of social justice, it seems to be worse in the African American and Black communities and communities of color. So this is just not helping like they say it's going to help. During the pandemic, there were, here in Colorado and other states, marijuana business was considered essential business. So even though the drug courts shut down and recovery centers shut down, they were still able to keep all of the marijuana shops open, just like alcohol shops. And if you look at the states on the left side that had a higher than 20% increase in drug deaths during the pandemic, there seems to be quite a bit of overlap in those states, same states that allowed marijuana businesses to be essential. So before I shift gears, I want to just kind of summarize this cannabinoid and opioid connection. Currently, there's zero evidence supporting the use of dispensary cannabis for chronic non-cancer pain. There's zero evidence for substituting opioids with dispensary cannabis. There's no package insert for dispensary cannabis. If you look and go to the drugs.com and look at dronabinol or tetrahydrocannabinol, which is the synthetic THC, and you look at they have a package insert. The starting dose for dronabinol is 2.5 milligrams of synthetic THC. And I routinely see patients in my office coming in consuming 5,000 milligrams of THC, 7,000 milligrams of THC. I had one patient, 8,000 milligrams of THC in one day, where the starting dose of the cannabis-based medicine is 2.5 milligrams. Cannabis users are more likely to develop opioid use disorder, misuse their opioids, have higher negative psychiatric effects. States with medical marijuana programs typically have higher opioid overdose deaths. So any real benefit, because from a molecular perspective, it should work because it works similar to opioids. But when you translate that into real world data, it's not helping. So any real benefit or perceived benefit is certainly at this point in time far outweighed by the current evidence. I'm going to talk a little bit about the pandemic. During the pandemic, a significant number of people increased their use of alcohol and cannabis went up a lot, not as much more than benzodiazepines and prescription opioids. In Canada, I think this was a Canadian study, past 3-month cannabis use significantly increased from 14% in 2018 to 20% in 2020. So significant rise in cannabis consumption during the pandemic. A lot of reasons people are given a cannabis recommendation is for a chronic condition. But one of the risk factors for COVID is a chronic condition. And this was a very large study of nearly 580,000 data points, and looking at breakthrough infections in people with substance use disorder. And so the risk of breakthrough infection was about 6.8 for tobacco use, 7.8 for cannabis use disorder, all significantly higher than the 3.6 in non-substance use disorder population. So almost twice as much higher risk for a breakthrough COVID infection for anybody with a substance use disorder, but it was highest for cocaine, which is less common, as well as cannabis use disorders. So cannabis use disorder is a risk factor for a breakthrough COVID infection. I'm going to talk a little bit about adolescent use, which is a big problem here in Colorado. You can see the number of child poisonings over time going through 2020. If you talk to any of your emergency medicine colleagues in maybe in Idaho, maybe not as much there as in other parts of the country, like in California or Colorado, they're seeing on a daily basis marijuana poisonings. And right now, the data is showing that marijuana poisonings in the kids 0 to 5 years of age is the #1 substance poisoning in the country at this point, much more than other ingestants. And the thing is that a lot of the kids that actually end up in the hospital are not part of this poison control data set, because this data set is people they're at home. Johnny got into grandma's cookies. Johnny's not acting well. What do I do? And most of the time they don't go to the hospital. So you can see, and this data in Colorado is what's happening across the country as in other states that have medical marijuana programs. So little kids are getting a hold of this. And if you're looking at the very young population, 0 to 5 years of age, 4% of these kids actually end up on a ventilator. So because they don't process cannabis like adults do. So it's much more dangerous in the young person or very young person. Adolescent cannabis use went up during the pandemic. Where do the kids get their cannabis? I mean, most of them get it for free. About half buy it from somebody. 16% have a valid medical card. As I outlined, it's very easy to get a medical marijuana card here in Colorado. It took me a matter of 1 minute. I did get my renewal earlier this year. That was a matter of 1 or 2 minutes of me not saying much of anything, and the same doctor just typing in information and sending it to the state. About 4% grow it as well. So, our kids they're going to do stuff. And if you expand the cannabis, they're going to get their hands on it. Sam Wong, who was a pediatrician, emergency medicine physician in Denver, looked at increases of emergency department visits post legalization of kids, adolescents presenting the emergency room. And you can see de facto legalization in 2009, and annual emergency department urgent care visits continue to rise, with 71% them being for psychiatric events. So you're talking about suicidality, psychosis, anxiety, panic attack, self-harm, that sort of stuff, 70%. And I published a paper on healthcare utilization in my community, and one hospital lost a lot of money in a short period of time, 20 million in 6 years, just from marijuana-related ER visits. And we did random chart reviews, and it was very heavy in the psych presentations, particularly in youth. This is some of the products that we're seeing in our emergency room. Here's a 12 and 14-year-old child that got a hold of a marijuana product, reportedly from a dispensary owner, probably a black market product, but they still have packaging. And this particular product had 500 milligrams of THC in this rope, and these 2 young children split it and had problems with it and ended up in the emergency department in Pueblo. But the problem with this product is, does it have 500 milligrams of THC in it? In the back, it says there's 420 milligrams of THC in it. We don't even know. I think they were just trying to poke fun at the 420 holiday on this backside of this product that had obvious mislabeling. So what is in this product? We have absolutely no idea. The label says 2 different things. What's actually in it, we have no idea. Here in Colorado, just a few months ago, the Marijuana Enforcement Division conducted only 80 underage compliance checks in 2021. And if you compare that to the Liquor Enforcement Division, they had 2,400 compliance checks and half the number of employees. So they do 25 times more underage compliance checks for liquor than they do for marijuana, with half the number of employees. So we are not doing a very good job protecting our kids. This is a paper I referred to earlier about this JAMA Pediatrics in 2021. Within a year of first trying marijuana, about 11% of adolescents, younger adolescents, 12 to 17 years of age, become addicted to it. In opioids, it's about the same, about 11.2% compared to 10.6, 10.7%. Within 3 years of trying the drug, 20% of adolescents became addicted to it, which is twice as much of the opioids of that same age group. And I have a little graphic here. So if you look at this picture, if you look at the cannabis first-time users between 12 and 17 years of age, addiction rate after 1 year is about 10%. If you look at opioids in the same age group, 2 lines down, the addiction rate after 1 year is about the same. If you look at that line 1 and 3, 3 years later, the kids that started at the younger age, 20% are addicted to cannabis, and only 10.6% of those kids are addicted to opioids. So it seems that cannabis has a much higher addictive rate in the younger onset users. If you look at the older age set, the 18 to 25 years old, similar addiction rate at 1 year, 6.4 compared to 6.9%, and a little bit higher 3 years down the road, 10.9 to 7.3%. And obviously heroin is a very, very high addictive rate. But in this particular paper, came from JAMA Pediatrics, well-respected journal, cannabis seems to have a much higher addictive rate in the younger onset users. It's very important to protect the kids and their brains. Here is a paper that I'm going to get there's kind of a purpose to putting this slide in here. JAMA Psychiatry a couple years ago looking at young adults to adults 20, 50 years of age. People that have depression are at a higher risk of cannabis use, especially in the ones using daily or near daily cannabis use. And those people with depression had double the odds of using cannabis compared to people without depression. So there's this definitely link between cannabis use and mental health. This paper shows self-harm and mortality risk about a year and a half ago. Cannabis use disorder is a common comorbidity and risk marker for self-harm, death, all-cause mortality, unintentional overdose, homicide of kids with mood disorders, and cannabis use disorder was significantly associated with non-fatal self-harm and all-cause mortality. So again, this problem that we're having, particularly in the adolescent world, of a risk marker for self-harm. And here, this paper, I think, kind of dovetails into this, another American Academy of Pediatrics paper from a year and a half ago. Adolescent prescription opioid misuse has an increased risk for suicide-related behaviors. So we already know that there's a direct link between cannabis use and suicidality. I outlined earlier, based on the Youth Risk Behavior Survey data, kids that use cannabis have a higher risk of opioid misuse. Again, that's the number one predictor, as I mentioned earlier, of adolescent opioid misuse is having used lifetime use of marijuana, having ever used marijuana. This paper kind of supports the next step. Kids that are misusing the opioids might be at a higher risk for suicide-related behavior. So is there a progression based on the Youth Risk Behavior Survey data of adolescent marijuana use leading to opioid misuse? And then this paper is showing adolescent opioid misuse leading to suicidality. Here in Colorado, marijuana is the most prevalent substance found in completed teen suicide in our state. It never used to be that way. Before we've legalized it, I think this is just a strange coincidence, or maybe there's something there or not. I can't prove a causal relationship. But in 2012, the roles reversed. It went from alcohol being most prevalent in completed suicide in our state. And in 2012, marijuana took the lead, and it's just gotten worse and higher percentages every year since then. And you can see on the left-hand side of the screen, kids that had depressed mood, mental health problems, treated for mental health problems, crisis, suicide note, etc. Those are the ones that tend to end up committing suicide. Here's one of my intake forms. I have a young man who works at an autism center as a respite therapist. And I asked him about his marijuana use. He uses recreationally every hour of every day. You can see down kind of in the middle of the screen. So I was kind of caught in a quandary with this young man, because I'm like, do I have a duty to report him to his employer for taking care of children with autism? Or am I going to violate HIPAA by telling his employer the patient's name? So I really was stuck and wasn't able to do anything about this, unfortunately. But as a parent that might have an autistic child, this would be a big concern for me if I knew that person taking care of my child was using marijuana every hour of every day. And when I ask my patients, when they fill out this form, I go, what are you using? Are you vaping? Are you eating? Are you smoking? Or what percentage, what potency are you using? Most of the time they have absolutely no idea. No idea. Some that are probably long-term users can tell me, yeah, I use 5,000 milligrams a day, 7,000 milligrams a day. But that's a lot of THC in a day. CBD is taking over the market. It's not psychoactive. It's, they have massage oils and all this other business. But if you look at, and one of my platforms is this product integrity concern. This is an article from JAMA several years ago, going into legalized places in San Francisco, Los Angeles, Seattle, looking at CBD products and labeling and accuracy. So in regulated markets several years ago, if you got a CBD product at a dispensary regarding CBD, only 60% had detectable levels of CBD, and only 17% that said they had THC in it were labeled accurately. So a lot of mislabeling. And my patients, I have this conversation. I say, buyer beware. What's inside the bottle may not be what's on the label. This is the CBD sold online. The concentrations are all over the map. And the ones that are being mailed across the country, 30% were accurately labeled. That's a big fail. 1/3 were accurately labeled, and 20% had THC in it, which the last I checked was federally illegal to be mailing these things online. This was a very interesting study that came out last year, and this is out of Massachusetts emergency department. And I'll go through this slide a little slower because it's important to understand. Patients that were presenting with a CBD dominant product or products that had an equal CBD THC ratio, there was no detectable CBD in 1/3 of them. So these are patients that are saying, I'm using CBD or CBD THC, 1/3 of the time, nothing in it. And in those that were saying, I'm using a CBD dominant product, 80% had THC in it. So again, this is a big concern from a quality control perspective, mislabeling perspective, public health and safety perspective. And the patients that were reporting a THC dominant product or an equal CBD THC product, they didn't even have THC metabolites in anywhere from 11 to 35%. So if you're purchasing a product that says this has THC in it, you may not have any THC in it 11 to 30% of the time. Patient of mine, who's a middle-aged menopausal woman, came to my office and she said when she tried CBD oil, she became suicidal. There's the same form that you saw earlier. So I mentioned earlier Epidiolex, which is FDA approved, purified plant-based CBD or cannabidiol. In my book, I'll get to later, of the people that got, the physicians that got Epidiolex FDA approved, Dr. Slavarsky and Dr. Gaston from University of Alabama, Birmingham. If you go to the Epidiolex website, and I would encourage you to do so, don't take my word for it, go to epidiolex.com and look at the warnings and precautions on CBD and the purified FDA approved product medication. The top three things you will see is liver injury, suicidality, and sedation or somnolence. So it's not safe to drive on these products. Yes, you can become suicidal on CBD. Yes, you can have liver impacts. So there's lots of concerns there. I don't know if anybody is familiar with the isomers that are being flooded in the market. This is thanks to the Farm Bill. So what they're doing is mass producing CBD from hemp, which generally has less than 0.3% THC by dry weight, which is very important to understand. But what they do is they take massive amounts of CBD and chemically change them into the Delta 8 THC, Delta 9 THC, Delta 10 THC, and they're called isomers. If you look on the right-hand side, Delta 8 compared to Delta 9, they have the same molecular formula. So all of these things are coming from CBD. Some states restrict them, like Colorado, we have restrictions on isomers. We can't sell them in Colorado. Florida, on the other hand, it's anything goes. You can buy Delta 8, Delta 9, Delta 10, HHC, THCP, which I'll get to in a minute. THCO, which is the acetylated formulation. It's not naturally occurring. It comes from federally legal hemp. Again, the Farm Bill, I think, has created a disaster. And I know Idaho is very rural. This is coming down the pipe. I'm sure it's already there. If you look at THCO, it was weaponized by the US military in the late 40s as a chemical warfare agent because it eroded dogs' muscle coordination twice as fast as conventional Delta 9 THC. And as an analogy, if you look at the acetylated products of drugs, heroin is the O-acetate of morphine. And we know heroin is more potent than morphine. It's more deadly than morphine. The THCO is the O-acetate of THC. So it is more rapidly absorbed, has a higher impact, rapid onset, and obviously trouble with coordination, et cetera. Here's THCO, 3 times more potent than Delta 9. It's not found naturally. People who have taken THCO say they describe it like a trip, not unlike someone that's taking psychedelics. You have mislabeling. Here's 50% of hemp Delta 9 products mislabeled can get you higher than cannabis. CBD is actually a precursor of THC in electronic cigarettes. I mean, I'm not going to have time to get into the vaping crisis we had and the volley where some people died from either vitamin E acetate or THC, most of which were black market, some of which were legal market that people had died from or needed lung transplants, et cetera. But THC was the main product when you heat CBD. And so here's some products in Colorado. Here's a Charlotte's Web hemp product that's sold at Safeway, a grocery store in Evergreen, Colorado. They're very expensive. There's nothing on the label in this hemp product about what the CBD content is, what the THC content is. But here's the certificate of analysis. And this particular product was about the equivalent of a capful of NyQuil, it's about 30 cc's. And so there's nothing in the label, but inside there's 84 milligrams of THC, the second from the bottom line. You can see this thing is loaded with THC. And actually, the hemp, again, I mentioned is 0.3% THC by dry weight, but they don't use the hemp product in dry form. They reconstitute it into sesame oil, avocado oil, et cetera. And once you reconstitute it, it goes from 0.3% to 3.0%. So it's a lot higher concentration in non-dry weight form. So the industry has failed across the board in many avenues. If you look at the Oregon Secretary of State marijuana audit from a few years ago, they only inspected 3% of stores, 1/3 of growers for compliance, which for me is a big fail. I mean, Oregon's had a very robust medical and recreational marijuana programs for many years. They couldn't ensure that the testing results were reliable. They couldn't assure that the products were safe for even human consumption. California has an 18% fail rate for pesticides, solvents, bacteria, including E. coli and salmonella. Colorado doesn't test or recall regularly. There was a nationwide recall of undeclared sildenafil or Viagra in products out of Florida. They can be dangerous if there's drug interactions. Florida recalled 17 million ounces of flour that had fungus called aspergillus in it. Here's Colorado recalling heavy metal arsenic, yeast mold back in October of 2020. It says return your product. You know, this is like months later go by. So to me, I mean, I don't think anybody is sitting on their product waiting for a recall. Those products are gone. We had cadmium, which is a known carcinogen, birth defects, can injure the kidneys, can cause pulmonary edema, anemia. So here, March 21, return your products from November 20 through January 21. Those products are gone. So this is basically human experimentation in my mind. Just a few months ago, we had yeast and molds. They failed contaminant testing. Again, February 22, return your products from 2 months earlier. Here in California, I mean, the industry, there's so much corruption going on. Here's a lab in Sacramento, the capital of California, faking the test results. They were faking the results of 1/3 of the pesticides they were required to test under California law. So 850 batches, tens of thousands of pounds of flour and other products like oils and vaping material were under the recall. So these are the ones that they found. I mean, how many did they not find? Nevada, they were faking the lab data. They had potentially dangerous contaminants. They were hiding those presence. They were inflating THC levels. There were pesticides, heavy metals, microbials, microtoxins. They would put the sample through 5 times before they would, quote, pass it. They were inflating the THC level because they're going to get more money for it. So they didn't dispose of stuff, nearly 12,000 samples. I'm going to cover some of the other medical impacts. One of my authors, Robert Page from Denver, is a pharmacist. He was the lead author on the American Heart Association paper showing that cannabis users might have a higher risk of heart attack, stroke, arrhythmia, sudden death, brain. This was a nice paper in New Zealand. They followed these patients over decades, and they retained 94% of them. So that's a really good study, prospective long-term study. Long-term cannabis users showed an IQ decline from childhood to midlife, about 5.5 IQ points. They had more difficulty learning. They had difficult processing speed compared to their childhood IQ. So basically they became dumber. The could not be explained by other co-founders, like tobacco, alcohol, other illicits. A part of the brain, the hippocampus, showed smaller volumes, and that's an area of the brain that modulates memory. So long-term cannabis users show significantly smaller areas of the brain that process memory. I use this slide very often in my presentations. This is out of the state of Texas. I mean, I've gone to the Texas Medical Association several times, the Texas Pain Society many times, talking to my colleagues. I always get deer in the headlights. But if you look at the child abuse or neglect fatality in the state of Texas, what substance, active or past use, is found by the perpetrator? And Texas is probably the only state I've worked with that looks at this data. Even Colorado, I cannot find this data as readily as I can in Texas. So if you have a dead kid in the state of Texas from abuse or neglect, the most common substance by the perpetrator, either current use or past use, as you can see by far, is marijuana. Followed by number 2 on the right-hand side by we don't know or nothing, followed by alcohol, again, then the usual suspects. But if you, again, a dead child in Texas, which represents about 10% of the entire US population. So I think it's probably a good reflection of what's happening in other states. Is this Big Tobacco 2.0? I think it's following the same playbook. April this year, they had a paper on the cannabis lobby in Colorado. Only 48% or 48% of lobbyists didn't even disclose their funders' cannabis affiliation. And the cannabis organizations use strategies that may have obscured the true amount of their funding and source of funding. So they were hiding it. Tobacco companies, Altria and Imperial brands, British American Tobacco, they have made significant investments in cannabis. So this is basically Big Tobacco 2.0. They went lifelong consumers. I'm going to kind of fly through some of these other slides. This is in Denver. In Colorado, recreational, you can have up to 12 plants. I see a few more than 12 here. This is a DEA going into a very nice neighborhood in Denver. They're wearing hazmat suits, rebreather masks. Part of it is because they don't know what poisons might be on these plants. One of the products that are found is an antifungal agent called mycobutanil. So they keep the aspergillus and the fungus from not growing on the plant, but there's no cap on the residual amount of mycobutanil on marijuana. And if you heat mycobutanil, that converts to a chemical we all know as cyanide. You have, these are pictures from DEA that I have about the elaborate electrical wiring that are being found in these grow houses. There's, tripping hazards, entanglement hazards for first responders. I mean, these are very, very elaborate electrical grids in people's homes. You have commercial grade lighting and heating elements in somebody's house. You have do-it-yourself ventilation. They're poking holes in the drywall, in the stairs outside the house, because these things need a lot of ventilation. And the agent in charge in Denver, who has since left, I had a discussion with him about this, what happens when the structure of the home is altered. And there's something called an R30 rating, which my understanding, correct me if I'm wrong, is when you have an R30 rating, it's about 30 minutes to get out of the house if your house catches on fire. But when there's no requirement to disclose your house as a marijuana grow house in Colorado, like most places have a disclosure for methamphetamine. If your house was a meth house, you have to disclose that if you knew it. But in the marijuana world, you don't have to disclose that, even if you know it. So agent in charge tells me when you alter the structure, they'll patch it up, they'll paint it, it looks pretty, smells nice, young family moves in, your R30 rating becomes an R5 rating. You got 5 minutes to get out of the house. So you have more than 6 plants by my view. You have mold growing out of the house. You have mold in drywall, which is not a good medium to grow crops. This is a marijuana house in northern Colorado. In Northern California, if you look at the Shasta Vista area, back in 2017, there's a Google Earth, and then you fast forward to 21. The law enforcement folks I work with in Northern California tell me that nearly all of these white dots represent an illegal hemp or marijuana grow with no building permits, no permits for water. They're stealing water, they're trading water, they're plowing the roads to these so law enforcement can't go in and investigate. They're finding things at these grow houses in Northern California, or these illegal trespass grows in the national forest, ram, deer, bear, mountain lions, everything. They're diverting water where salmon don't spawn anymore. I know Idaho is very huge in fishing. I'm sure this is happening to some level in Idaho, in remote areas. And the marijuana growers aren't nice. They don't put it back after the harvest. They just let these irrigation tubing and lining lines just keep going. And so that the streams dry up, the salmon don't spawn. So that, they have fire hazards. Here they have a banned pesticide called carbofuran, which is in 100% of the grow sites in California. You're not supposed to have it. You have the insecticides, you have trash. DEA doesn't even go to about a third of the grows in California, which they predict about 80,000 grows total. They've got booby traps. They have snare wires. They have dead animals everywhere. In Oregon, which is right next door to you guys, 4,000 pounds of trash from illegal marijuana complex in the Klamath River watershed. So they don't know what to do with it. They're dealing miles of plastic water line. They have to helicopter all this crap out of these illegal grows. In Oregon, they don't even know. Here's a high school that has all those little grows behind them. They don't know how many are legal or even licensed. They're right next to a high school. They're all over the state. We're in the midst. Idaho has to deal and contend with wildfires. We've had a terrible wildfire season in the West. We're in drought conditions. April of last year, the Dolan fire in California killed a firefighter, started intentionally by an illegal marijuana grower, and was found guilty of arson, 10 homes destroyed, 125,000 acres, nearly cost the lives of 14 firefighters at a cost of $62 million. So in summary, marijuana is not a medication, it's a plant. We have a lot of plant-based medications already. I do support FDA drug development for cannabinoids, including evidence-based dosing guidelines of cannabis-based medications. I support that process. We already have 3 synthetic, maybe 4, I believe, cannabinoids. We've got Epidiolex, we have dronabinol, we have nabilone. We know how they work. We know how they're dosed. We know what the risks are. I think we should support a potency cap of 10%, maybe 15%, if you push me a little harder. I didn't have time to talk about cannabis psychosis. Home grows should not happen. They're simply breeding grounds for illegal activity. Monitor the public health impacts and healthcare utilization, emergency room, birth defects, et cetera. Publish environmental impacts. Mandatory drug testing for all violent crimes. There is a thing called cannabis-induced psychosis, or CIP. I just submitted a paper for review on cannabis psychosis. One example in Colorado, Richard Kirk, in 2014, gobbled up a bunch of marijuana edibles, became acutely psychotic, and his wife freaked out, got on the phone with 911. And while she was in the midst of her 911 call, he shot her in the head, killed her in front of her children. And I have his toxicology report, and there was only one substance on his toxicology, and that was THC. Watch your kids, monitor their use very closely, discourage smoking and vaping. I did not have time to get into the impacts on pregnancy and lactation. Test suicides, including adolescents and adults. Texas, even though they had that nice slide, they don't do that routinely. I think it's important that this be done routinely, because this is a very insidious and covert substance. Monitor marijuana related driving fatalities. During the pandemic, we heard, follow the science and listen to the doctors, but in marijuana world, it's follow the money. It was the impetus for me for editing a medical level textbook with 70 authors in 4 countries, 20 chapters, covering a variety of impacts across multiple areas of medicine. And it was also the impetus for founding a nonprofit called ISAC, the International Academy on the Science and Impacts of Cannabis. You can go to our website. We have free talks, kind of like this talk. They're recorded for prosperity. We're kind of wrapping up our 2022 season. We'll be gearing up for 23, probably in January, but between November 21 until about a month ago, we had almost a weekly presentation by somebody, an expert in their field in medicine, talking about how marijuana is impacting different aspects. We had one of my favorite was a gentleman from Harvard University talking about ADHD and cannabis as a toxic couple. It was absolutely fascinating and very easy to understand. But you can go to our website, you can look at it. It's free to register. It's free to watch at your convenience if you're bored. But I'm going to stop there and open it up to questions. I know it's drinking from a fire hose, so a lot of information.
Dr. Finn, can you talk just a moment about, you said that you polled everybody as far as if they were vaping or smoking. Can you tell us kind of the breakdown of how vaping is showing up on that form of intake?
It's all over the map. You know, if a patient comes to me and I ask them if they're using medically or recreationally, they may say yes. And then I'm limited by time, obviously. But when I ask them about, are you vaping? They say yes. I said, well, what are you vaping? Are you vaping CBD? Are you vaping THC? And if you're vaping THC, what potency are you using? They have no idea. They don't know what they're taking. They just say they vape anywhere from twice a day to 10 times a day. You know, they have no idea most of the time. A rare patient will come in and say, oh yes, I vape 80% THC 12 times a day. Rare, that's a rare bird. Most of the time they're either eating it, smoking it, vaping it, or ingesting in other manners. I mean, they have marijuana tampons, they have marijuana rectal suppositories, they have marijuana eye drops. If there's any way you can get it into your system, there's a way to do it. You know, I was speaking to South Dakota about a year ago to the legislators there, and when I was done, I was given I would consider it a compliment. One of the legislators in South Dakota thanked me for the front row seat to the horror show, and I said, "Well, thank you." I said, "You know, you have to be careful because this is what I tell states that I work in now." Is Colorado and California and Washington and Oregon had what we would describe as unintended consequences. We didn't know these things were going to happen. It was like, well, it's just marijuana. We didn't have any concerns about potency. We didn't know that the products were going to go through the roof. I mean, the dabs, waxes, and shatters are 95%, 100% claiming THC. They don't look like plants. They look like goo or wax. That's why they call it wax. It looks like earwax. In a very small amount, they heat a nickel nail and they vaporize this little waxy substance on a hot nail, and they inhale the vapors of, you know, there may be heavy metal poisoning, there may be contaminants in the wax. We don't know. They're not tested regularly, and they're very, very strong. I had a personal friend of mine who was a child of the 60s. She's kind of a hippie, and she saw nothing wrong with marijuana. And I asked her one time if she dabbed. And she said, once. And I said, well, what happened? She goes, I was walking sideways. She goes, I had to hand my keys to my boyfriend because I knew, she was insightful enough. I knew I could not drive. I was so jacked up. I had another patient who was a very experienced drug user, a multi-drug history, came to me, and I asked him if he ever dabbed. And he said, and this guy, well experienced with drugs, said one time. I go, why did you not do it? He goes, it reminded me of what I felt like when I used to shoot up crack cocaine. And this is marijuana. It's just the argument. It's just a plant. It's green, natural, herbal. We didn't have the chance to get into the environmental. I talked a little bit about the environmental impacts, but, you know, just as an example, in Colorado, the marijuana industry creates more carbon emissions than Colorado's coal industry. I mean, it's not an environmental friendly industry at all.
All right. Could you touch briefly the correlation between violent crimes and cannabis?
Well, it always seems to be at the dance. Again, I just recently published a paper, or I'm in the process of publishing a paper. There was Ian David Long as an example, who was from California, I think in the LA area, who shot up and killed 14 people. And I have his toxicology report in my hand, and there was only one substance in his system. The Uvalde shooter in Texas, known marijuana user, we cannot have access to his toxicology. The Highland Park shooter in Illinois, again, known marijuana user, cannot get his toxicology. But in 2018, I think his name was, what was his name? There was a gentleman who had a disgruntled worker in somewhere in Illinois, killed 4 coworkers, injured, wounded 4 or 5 law enforcement officers, and then killed himself. And I have his toxicology, and there was only one substance found in his system, and it was THC. So for me, what I am seeing is kind of a common denominator in these violent crimes and cannabis use. The Planned Parenthood shooter here, very known marijuana user, can't get his toxicology because it's an ongoing investigation. But 3 weeks before that, we had a shooter in downtown Colorado Springs, which is a very conservative part of Colorado. We have a lot of military here, highly military penetrant community, very conservative. But we had a guy with an assault rifle downtown Colorado Springs, kills an ex-Marine, kills 2 women. Before police showed up and they killed him. And I had his toxicology, and there's only one substance on his toxicology. So it just seems to be at the dance more often than people really want to look or think. And that's why I think it's important that states that want to go down this road, you need to do mandatory drug testing on any violent crime, period, and publicize it.
Okay, we have another question. Do you see a relationship between using marijuana to self-medicate for mental illness and using it for pain?
That's a kind of a two-pronged question. My colleagues in the psychiatry world do not support cannabis use for treating any mental health condition, depression, PTSD, et cetera. I know there's a push for veterans to treat their PTSD or self-medicate with cannabis. I have big concerns about that because the data simply isn't there that the cannabis users that are veterans for treating for PTSD, the outcomes are worse for those. I actually had a discussion with the primary investigator in Texas on the Chris Kyle. I don't know if you remember the American Sniper that made a movie at it. And he and his friend were killed by another gentleman who they didn't do toxicology, but I spoke to the chief investigator and the guy was a very heavy marijuana user. So again, another dot to potentially connect this link between violence and cannabis use and mental health. It hasn't been proved to treat mental health. As a pain medicine physician, I personally believe there are components of the plant that might be helpful in pain. Molecularly, it's supposed to work. But when you get into the world of dispensary cannabis, they're poorly regulated, poorly tested. They don't meet the definition of medication. We already have synthetic THC that nobody asked me for. I would gravitate more towards using dronabinol or nabilone for a patient with pain over the garbage that they're getting in the dispensaries. But it still, to this date, has not been proven to be very effective. And as a scientist, I'll bite off on a prospective, head-to-head, double-blind, placebo-controlled, multi-center study proving a cannabis-based medicine like dronabinol is superior to an opioid like Percocet or oxycodone.
All right. There are studies that show how the body recovers from cigarette use over the course of several years. Are those similar studies about cannabis use?
I think the answer to the question is yes, especially in the mental health arena. If you have somebody that has cannabis psychosis, as an example, if they stop using, the psychosis will likely improve over time. However, there are well-documented, there's a percentage, I don't know what the percentage is, but if you have a person that has cannabis-induced psychosis or CIP, and they stop using, the vast majority of the time, the psychosis will resolve. It may not resolve tomorrow. It may not resolve for 2 or 3 weeks. And in occasional instances, it may not resolve ever at all. Sometimes it's a bridge you just cannot uncross. So it's very, and that's one of the things I talk about is like, give me an example of a medication that will cause psychosis to the point you kill somebody. There is no medication I'm aware of that will make somebody so psychotic they will commit murder.
All right. For our other listeners out there, if you want to type a question in the chat box, I'll be glad to deliver it. Bruce, did you have any other questions?
I don't know if he heard you. Oh, somebody said, any thoughts on tinctures? Yes, I do have some thoughts on that. Again, product integrity. What is in that tincture may not be what's on the label and vice versa. So I tell my patients that maybe using tinctures, buyer beware. As an example, I did have a patient who had, or at the time thought she had Lou Gehrig's disease, but also had severe nerve damage from a spinal cord injury she had. She was, again, a child of the 60s. She goes, I don't want anything with THC in it because when I was in college, I smoked probably a 2 to 4% THC product. She had a rapid heartbeat. She became paranoid. And she said, well, I have a medical card and I want to go to the dispensary. What are your recommendations? I'm like, well, I don't really support you using it, but if you were to go to the dispensary, try to get something that doesn't have a lot of THC in it. So off to the dispensary she went. She got herself a tincture, which, by the way, is very expensive. They're pretty pricey. And the person behind the counter, I don't know if you're familiar with the term bud tender, but they're called bud tenders in the marijuana industry. They're the people behind the counter. And the only requirements to be a bud tender in the state of Colorado is 21 years of age, have some familiarity with marijuana, and have a pulse. There's no medical requirement. They cannot have discussions on perhaps an elderly person that's on multiple drugs. They have no idea what their drug-drug interactions may be. So again, if there's and this patient came back to me and I said, well, how was it? And she said, you know what? I felt like shit. My heart was racing. I felt paranoid, just like I did when I was back in college. And so what she didn't realize, and what the bud tender didn't know, is that she was given a product called THCA, which is the pre-drug to THC in a tincture. And he was partially correct because THCA is not going to get you high. It's not psychoactive. But when you heat it, like if you were to smoke it, it's the product in the plant that when you heat it, undergoes a process called decarboxylation and converts into THC, and that's the psychoactive component. But what happens when you have an oral formulation, it goes through the liver and undergoes the same process, decarboxylation, and her THCA became THC, which is exactly what she didn't want. And so she says, I wasted $250 on something that I could have gotten for a $4 over the $4 prescription for her muscle spasms. So she was not happy. So again, my thoughts on tinctures: buyer beware.
All right. I don't see any other questions. Maybe if you could just wrap it back around to the title of our webinar tonight is what every parent should know about marijuana. What could you tell parents to tell their kids how to get this information to the kids?
Ooh, well, number one, kids don't listen to parents. Number one, and the kids don't listen to adults very well. I've been having this discussion with my colleagues that are in this space. I think it's important to find a kid that has had an experience with marijuana and may have become suicidal. One of my, I call her Shiro. You may be familiar with Laura Stack and her story, but she is a Shiro of mine because she had the unfortunate experience of her son Johnny committing suicide related to cannabis psychosis. So she has a lot of information on what parents can look for. Her organization's Johnny's Ambassadors. But what can parents tell their kids that kids are going to listen to? I'm afraid maybe not much. I think the best thing you can do is just talk to them all the time about it, because even though they may not be listening to you, the message still may be getting through. If you just talk and then give them ideas, give them examples, say, I heard that, and I only found this out about 6 months ago. I don't know if anybody's heard of THCP. Have you heard of that? Now this is the new these new designer drugs that are being created from hemp and CBD are showing up. THCP has 30 times more affinity to the CB1 receptor than Delta-9 does. So potentially 30 times more potent. And these are found in high schools in other parts of the country. And then you have the HHC, or the hexahydrocannabinol, which is the hydrogenated form. I think of margarine when I think of hydrogenated, but it's another isomer that's coming from hemp. And just have the open discussions about, you'd be surprised how much kids know. These kids these days are so much more sophisticated than I was at that age. They know more in this space than you will give them credit for, period. And I think it's important to have open discussions, even though you may think they're not listening, but maybe they are listening. And if you just continue and repeatedly talk about these things, sometimes the message may go through. But the other I found, speaking with Ben Court, I don't know if you've met Ben or not, but Ben is in recovery, but he works with a lot of adolescents. He feels that the best way to get through to kids is to find another peer that has had a negative experience and have them talk to those kids. That message gets hit home a lot quicker and harder than just a grown-up talking to them. They would not want to listen to me unless I was in the right environment, not on a Zoom, but maybe in person in a very roundtable discussion, fielding questions from the kids, because they're very, very curious about this and they know more than you think they do. And what they do know may not be 100% correct either. So I think it's important to have open discussions with kids, find peers, have them talk to each other. I can tell you, I suspect that most of the kids in Idaho that you are familiar with have been impacted in some way or in some manner, either a suicide or that may or may not have been related to marijuana. But letting them know that, why is marijuana found in kids that are dead from suicide in Colorado more than anything else? I think it's a what we call bidirectional relationship. Are they using because they're depressed? Are they depressed because they're using? I think it goes both ways, but there's no way to prove one way or the other. The fact is, when a child completes suicide in Colorado, that's what's found most commonly. I mean, we have kids that are, they don't ask for this. 70% of the dispensaries recommend women use during first trimester. And we know there's negative impacts to the brain. Patients of mine that are school teachers see kids coming up to the school in the cars driven by their parents, and they're hotboxing. I don't know if you know what hotboxing is when you roll up all the windows and you close all the vents, and the parents are getting stoned and there's all this smoke, and the kids sitting in the back and they get secondhand smoke and they're somewhat impaired. There's data to show there's impairment from secondary smoke. So those things are happening, and they may be happening to maybe a lower level in Idaho, but I suspect they probably are happening, and it's frightening. And the kids really need to be part of the conversation. I think you bring them in.
All right. Thank you so much. I just appreciate you so much being willing to talk to us out here in Idaho. And
I love Idaho.
Well, the kids have had a pretty one-sided bit of information on this, and it's hard to know how to balance that out and show them some of these things. But at least the parents might be able to understand this a little better. So thank you so much for coming on tonight.
Oh, you bet. Thank you for having me. I appreciate the time you take out of your day for this.
Yeah, and come back to Idaho.
Oh, if when I have time, I definitely will take you up on that offer.
All right. Well, thank you again. And it looks like we have no more questions. A lot of thank yous in the chat box.
All right. Well, thank you guys. Have a good night. Stay in touch.
Okay. Just so informative. I always come away with a whole page of notes after I've been listening to you. So
that's why
thank you.
Asking me back.
All right.
Take care.
Thank you.
Bye-bye.